successfully hit record. And we'll send out a link with basically a YouTube video for anyone to watch this. It'll be posted on our website, and we'll send it out sort of once it uploads today. Okay, so those are my housekeeping. Oh, no, one more housekeeping. Because this is a webinar and, we have so many people on the phone, we're going to take a little bit of a heavier hand when it comes to facilitating conversation. So whenever BHT is giving a presentation, if we have a speaker going, like right now as I'm speaking, we're going to have everyone on the call muted. So if you would like to ask a question in the middle of a presentation, please do so through the chat box or hit the little raise your hand button, and I can unmute you so that you can ask. Otherwise, we'll hold all questions until the end, and I'll pause at each section so that we can unmute everybody and ask for questions. I'm hoping this will just make it a little easier for folks to break in as needed, and also cut down on some of the chatter that we get when folks are, when we have so many folks on the line. All right, so with that, I think we are ready to dive in. The first bit of news that we have, oh, I forgot, I have one more card. So we've established a new practice that in our Leadership Council slides, I'm always going to include a de-jargoning card, which lists out some of the acronyms that you might find in this presentation, so that for your reference, you guys have those. For today, I think the big ones that are important are going to be FIMC, which, just a quick note on that, originally that it stood for Fully Integrated Managed Care. And since there have been an update that the level of integrated care we have right now is not actually 100% full, so there's been a request, and the Healthcare Authority has started changing their language to just calling it IMC, Integrated Managed Care. BHT is still lovingly using the F. We are advocating that this could be for financially integrated managed care, so that we don't have to be too confusing. But just as a note, as you're out and about, you might start hearing IMC. It's still FIMC. Other than that, I think that's sort of our big acronym for today. So hopefully that's a helpful resource. And then I have some great news, if you haven't heard already. BHT got back the results of our project plan that we submitted in November, and we received 100%. Along with all 9 ACHs, all of them were approved for their project plans, so everyone will be receiving their first round of project dollars come May. So we are really excited about that. It was a lot of hard work from the team. And if you haven't read the project plan, it's just riveting, and it's on our website if anyone is really diving in. We got one chat already. I love that. Oh, can't see the slides. Let me make sure those are up. Okay, tells me they're sharing now, so if you still can't see them, give me another chat. All right, so that's our sort of initial update. We are going to start today with a dive into our first round of funds flow allocation that was approved by the Waiver Finance team and the board just in January. So I'm going to turn it over to Alison to walk us through this.
Well, hello, everyone. This feels very exciting after 3.5 years of talking about the potential to actually make some investment in transformation work, and we are ready to sort of dive into that. I want to just set a little bit of groundwork here for you. One, this is the Medicaid transformation framework that we are using to really set our direction here. So you will remember from our Collaborative 101 sessions, the settings that we see being key for the Medicaid transformation. And I just want to highlight a couple of things here. One, these are the types of settings that we expect to be contracting with to actually receive Medicaid waiver dollars. This is not a comprehensive list of everyone who will be necessary for health transformation work, but trying to get really clear about our 4 project areas and sort of the additional pieces that we think are critical to get us ready for value-based payment. The second piece here that we're thinking about is really this regional infrastructure, and you will see in an upcoming slide, we've allocated some specific dollars to support the sort of regional nature of that infrastructure. The couple of things that I want to highlight in this is really the importance of payment reform and getting to transformation, and also what will increasingly be an area of focus, I think, for BHT as we move towards the end of 18 and into 19, which is really some policy and advocacy change work ahead of us. We have identified some core target populations, and I think this is always a little bit confusing in that we are talking about trying to transform the Medicaid population, but also trying to target some populations from within that in order to really have the meaningful impact on our metrics. We've identified these sets of target populations across our core work. And then because it has been a part of all of our work in thinking about both community-based care coordination and prevention activities, we still see some infusion of work around transition and diversion-related activities. Next slide. The who's in the collaborative. So this really matches up with the previous slide in terms of who we see being in contract with us. Next slide. And the collaborative work in 2018, I'm going to gloss over this because on Thursday we will release far more guidance on the very specific requirements in order to be able to earn dollars. This is designed to just sort of ground us in, it seemed like a lot more money when we were talking about $1 billion across 9 ACHs, but when you actually break it down, those dollars will have to be invested very, very smartly in order to have the greatest amount of impact. So you'll see here the project dollars. So when we talk about scoring 100% on our year one project, that should result in a $10 million investment to the region. The board late last year made a commitment that 30% of our project money would go to regional infrastructure, 55% to the collaborative, both the partners and providers in there, as well as just at a sort of system of care model, 10% to our community resiliency fund. And as we've stated in previous presentations, we're just starting to launch the work to identify how partners will access those community resiliency fund dollars. But the intent behind the board's approval of this is really how are we linking social determinants of health with the healthcare delivery system. And then we are going to keep the ACH administrative cost at 5%, making us a lean, mean machine in that way. Because the region selected, or because the county commissioners, I should say, selected to go mid-adopter for fully integrated managed care, the region has earned $8.6 million. And assuming all of the pieces continue to fall in place, 3.1 million of those dollars will be available for the ACH to invest in May of this year. The balance of the dollars will come in 2020. So with that, for 2018, these are the sort of 4 pots of money and sort of the timing we expect in terms of releasing those dollars. So last month the board approved approximately $6.6 million as sort of the potential to be earned by our partners, with the idea that most of those dollars could be earned by June 30th of this year, with a very intentional effort to try and push dollars out to our partners as quick as possible. In February, we are going to formally release all of the timing, and then as we move into March, April, and May, we will release some additional project management money, some community-based care coordination dollars, and also a set of recommendations for regional infrastructure investment related to the assessments that we are expecting. And then in May, I believe the board will approve the community resiliency process, and then we would release that formally in June. You will want to pay very close attention to the guidance coming out later this week and in the coming weeks of the exact dates of when these pieces will move forward. We've had no surprise, though disappointing, a little bit of complication in how soon dollars would be available to the region, and some additional policy work that the board has had to do. Next slide. So when we were thinking about the funds flow methodology, the Waiver Finance Committee really highlighted these key elements. So the first, as I mentioned, is really pushing a maximum amount of investment to providers and partners sort of as soon as possible. It is not the intent of Better Health Together to sit on the dollars, but rather get them into the hands of the folks that we need to be making the transformation efforts. However, recognizing this, we also wanted to hold back enough money that once we have completed our assessments, that we could really use those infrastructure dollars to address identified gaps. Because as you'll remember, as we move into year 3, 25% of our dollars will be tied to performance metrics. So we don't want to wait to do all of our investing in infrastructure until next year. So trying to really balance that out. It was important to note that in the collaborative structure, we were trying to both incentivize healthcare and social determinant of health partners to really prepare the region for value-based payment. This is going to be a really important point to sort of hold onto as we move into what the different levels of funding being available. I think the board and the Waiver Finance Committee, and quite frankly, all of us, really see a high value in investment in social determinant of health. And these are Medicaid dollars that should and could be invested in the healthcare system. So trying to really balance that out. And then I think sort of noting that this year's funding is really focused on planning. So there's a little bit more sort of equity across all partners and counties in this year, recognizing that it kind of doesn't matter how big your organization is, there's X amount of effort in order to plan and get ready for that. So we are trying to offset realized and anticipated expenses for planning. Clearly, when you see the numbers, you'll know we have not fully covered all of those expenses, but really trying to make some acknowledgement of the amount of effort it's going to be required. The other piece is that we are trying to really encourage to require sort of long-term partner participation and buy-in. We think that it is going to take the identified partners all working together over the next 4 years to really have the kind of impact we're all imagining. And so while we are not saying that, you know, you've signed in final, no way out, but we are really looking for a deep level of commitment to this work. And then finally, the last piece is really recognizing the important role that primary care and behavioral health is going to play in this transformation efforts, that a majority of the metrics that the region will earn dollars on really are connected to those two settings. So you will see a bigger level of investment in those partners than other critical partners as we move forward. Excellent. Maybe I'll just pause there, Hadley, and see if there are any questions from the audience. Otherwise, then we'll really start to move into the actual dollars, which I know is what folks are mostly interested in.
There's nothing on the chat, but I'll take a second to unmute everybody. So if you have a if you want to ask a question, now's a great time. Going once. All right, hearing none, you're back on mute.
Excellent. Okay, so I have found in making this presentation, both to the Waiver Finance Committee and to the board, there's a bit of, oh my gosh, what about? So we have created the snapshot view to try and get a couple of sort of key themes pointed out. So on the left-hand side chart, you'll see the setting totals, really demonstrating the amount of dollars by setting for this first round that we're investing in. So this really tracks with what I just mentioned around behavioral health and primary care, and yet really continuing to acknowledge the important roles that some of our other partners will play in this work. On the right-hand side, you will see the balancing of investment by county. I think this is a really important one to note here for a couple of reasons. So one, about 80% of the Medicaid population is in Spokane County, but we've worked really hard to create a balance of investment across all of our rural counties as well. So you'll see the percentage of dollars going to each of the counties on the outside of the graph, but on the inside are the actual number of assigned Medicaid lives in that region. I'm going to now move on to the next slide, where I'll walk through how those dollars are being, oh, no, I'm not going to do that first. I'm going to first talk about, actually, let's go to the next turn. Is there another, oh, there's not the, okay, let's go back. We'll go back. I got a little ahead of myself here. Let's go back one more slide. So on this slide, you'll see at the top, on the top line here, the project money plus the FIMC dollars. We have created a baseline investment for our collaborative partners by setting tied to participation, assessment, and implementation planning. Those providers who are in one of these identified settings will have an opportunity to earn those dollars. Let's go to the next slide. Additionally, for primary care and behavioral health providers, we wanted to really acknowledge that while there's a certain amount of investment that is required in order to do this planning, size does matter to some degree, and that as we move through this process, the number of lives served, affected, assigned, depending on how you want to think about that, will really matter. And so our volume equalizer will be for individual partners for a one-time payment based on the number of beneficiaries that they serve. So you'll see our tier one serving 501 to 2,500 beneficiaries would earn an additional payment of $5,000. Tier two, 2,500 to 25,000 to 15,000, and then tier three are more than 25,000 beneficiaries. We would love to say that we had awesome data from the healthcare authority to very third-party-ish assign those values, but what we found that was not the case. So this payment will actually be released based on self-reported data, and we develop these tiers based on our health systems inventory. So there actually isn't anyone who's at 501 or 2,500 where there's going to be any gap in payments because you counted one extra or not quite enough. So in the commitment MOU that'll be released on Thursday, there'll be a place for individual primary care and behavioral health providers to note the number of 2017 Medicaid beneficiaries in that way. The second additional earning potential is really in the equity accelerator. And as you all have encouraged us, and we have embraced this idea of really recognizing and continuing to invest in work that accelerates health equity is really important to us. And so, while not a perfect way to help support this, we did want to acknowledge our partners who were delivering service to more ethnically and racially diverse Medicaid populations. So, if you are matching up with what the region's ethnicity is of about 9%, so less than 10%, there is no additional earning. We would sort of expect everyone to be reflecting the population in general. If you were serving 10 to 24% ethnic diversity of your Medicaid population, there'll be an additional $25,000 payment in that way, and then more than 25% would earn a $50,000 payment. It's important to note that this is a one-time payment, though we do want this to be a signal that partners who are working to deliver more services to ethnically and racially diverse Medicaid population will be likely rewarded as we move forward. This payment too will be a self-reported percentage for the region. There is not any healthcare authority data that actually looks at this at a provider level. So again, when you complete your MOU form, there will be a place for you to attest to the percent, and that will trigger the additional earnings. So that sort of gives you the overall collaborative partners earning potential. The next set of funding opportunity is exclusively for behavioral health providers, and so I want to walk through this in a couple of different ways, because we're looking at it through a couple different lenses. So first off, we have identified about 33 currently BHO contracted mental health and substance use providers who are actually delivering services. So we recognize that the BHO also contracts with some support services, and we think that is excellent, and those partners likely fit into our collaborative structure, but not for fully integrated managed care readiness funds. The second sort of categorization are our Native and tribal behavioral health partners. These are partners who may currently be in contracts with managed care organizations or are delivering services that are not funded through the BHO. Part of the reason for the differentiation in this is that their readiness for contracting with MCOs is greater than the BHO providers who have just had a different system in general. It should not be taken in any way that we don't see that work to be equally as important in that, or equally as important. The next piece of the FIMC funds is, I'm going to actually jump down to this technical assistance. For every provider, either BHO contracted or Native and tribal behavioral health partners, we will also provide a $20,000 technical assistance investment. These dollars can be used at the individual provider's discretion to help support build their dollars. We may suggest to you that you would pool those resources to have them go further, but they would be at the discretion of each of the providers to make that decision. So you'll see that for currently contracted BHO mental health and substance use providers, their potential earnings from these FIMC dollars is $70,000, and for our Native and tribal behavioral health partners, it is $45,000. Additionally, we have allocated $50,000 to each of our rural counties to help support this readiness and set of sort of new infrastructure that needs to be built. It will be up to each of the rural collaboratives to tell us how they would expend those dollars, and then we would release those dollars completely. Finally, I would say that we were very intentional in allocating payments by provider, regardless of the volume or the service area. So what we do know about some of our contracted BHO providers is some are seeing 25, 30, 60% of the Medicaid market, and some are seeing a very small percentage. We are saying that getting ready for financial integration sort of takes a set of work. If you are a provider who is operating in multiple counties, it's still a single set of contracts that you would be putting in place. So we feel really confident in this model that it sort of balances out rural and Spokane County needs and providers with high volume as well as small providers as well. Our calculations are based on 31 partners being engaged, and I think it's important to note that a behavioral health provider may choose to access FIMC funds but not access or be part of one of our collaboratives. There's not a requirement that you participate in the collaborative, so we would say we would welcome all of them in that way. You will see the last thing that I will note is if all 31 partners participated, we would expend about $2.3 million, leaving us roughly $800,000 that we are imagining will be allocated towards EHR readiness to ensure that we are ready to go on January 1, 2019. Part of the holdback of those dollars and how we would expend that will be dependent on the FIMC readiness assessments that we are requiring for each of our partners to actually trigger a portion of this payment so that we have great information to really figure out how to move forward in that. Again, our intent will not be to sit on those dollars, but to allocate them in a fairly quick time, recognizing that January 1, 2019 is coming very, very fast. So I think with that, we'll pause for any questions that folks might have.
Everybody's off mute if anyone wants to ask a question. Going once. Okay, and I'm muting you all again.
Excellent. Well, I think as I mentioned that later this week we will be releasing our more formal guidance and how things will very specifically play out, but we wanted to just sort of show you directionally where we were headed.
Okay, we did end up getting a question. So our FIMC funds to providers, FIMC funds to providers are specifically for developing integration infrastructure. Is that correct?
Oh, that's a great question. That would be our intent, though. Once you have met the milestone and we have released the payment, how you expend the dollars will be at your discretion.
And Linda is asking if we reinstated the February 22nd deadline for letters from partners, and I'll be talking about that in just the next section. And I apologize, I noticed earlier in a slide I forgot to delete where it said somewhere that we expected those by February 22nd, but we did delay that based on some of the bumps in the road.
But good catch, that makes me think that you were actually listening to us, so gold star for you today.
All right, I'm just gonna be quiet for one more minute in case anybody else has a question or wants to type something into the box.
There's purple badge. I'm ready for you. I'm going to get you lined up in a particular order. But before I do that, we have something kind of unique today.
And I'm muting again.
I'm pretty sure that was not a question, but I want to know what you get a purple badge for.
Dan asked, what is the milestone? And I think actually in the next section, I'm going to go through some of those milestones for both the payouts for collaboratives and for FIMC payouts. Okay, so this is a good question from a social determinant partner. Is there an opportunity to get more involved in the community resiliency process?
Absolutely. So our intent for helping to frame out the community resiliency sort of principles will be to work through all of our technical councils to provide feedback from that set of perspectives. And I expect that we will do some all-call, what are things that the broader community needs to or would like to see in that way. We will be super transparent in sort of the process as it develops, and I would expect at the April Leadership Council meeting we'll have an opportunity for the Leadership Council to react to sort of our summarized work. And if you have specific thoughts and ideas about what should be part of that, shoot them my way, and we'll just add them to the discussion points that we've put forth so far.
And could you describe what it means to be a partner in the social determinants category?
Sure. So let's go back to the slide of who's in the collaborative.
Forward.
I think that will sort of help. So we are prioritizing social determinant of health partners who are working in the food, housing, and transportation space right now, because those are really the highest identified needs that we see from our healthcare providers. And again, sort of recognizing that it felt like a lot of money when we said $1 billion, and now that we're down to what will be sort of the high-end potential in our region of probably $60 to $70 million. We wanted to be really clear that we needed a depth of investment, not spread across a number of partners. So I think you'll see in the collaborative development that prioritizing of those three areas. I think there is still a lot of room for influence on other social determinant of health partners that may be funded through the Community Resiliency Fund, though I think it is not a significant amount of money that I would foresee a very broad set of partners. I think we will continuously have to be very targeted in how the Medicaid transformation dollars are invested. That being said, if you remember back to our Collaborative 101 slide, we see a tremendous opportunity of using this collaborative structure to actually weave together other types of funding, and that through these sets of relationships, which, while there is a lot of good intent, I think, all over the region to work together, there's not ever been a more formalized structure, which we think should make us very competitive for other types of funding, whether it is state and federal government funding or philanthropic funding. So I am sure it feels slightly harsh if you are a social determinant of health partner who is not food, housing, and transportation. And we in no way want to diminish the important social determinant role that you play, but for the Medicaid waiver dollars, we do see a level of focus on those three partners.
All right, that's the end of our questions in the chat box. Those were great questions. I'm going to pause just another 30 seconds or so in case anyone else wants to add something. All right, well, thanks for your questions all. I think we're going to move us along to the next section of our meeting today. So I just want to take note that also in this section of the slides we've included, again, some terms, sort of de-jargoning some of the terms that you saw in that section, and then also included the guiding principles and sort of the needs that drove the funds flow decision. So these are here as resources, and don't forget that you can click the materials tab of the little webinar box and download the slides, and we'll also send them out afterwards. Okay, so now we are going to do a quick sort of high-level run-through of the next steps for the ACH, and specifically what's coming up for the collaborative and with this MFIMC commitment, and what we're going to include in the release on Thursday. So first we want to give just sort of a quick update of what's been going on in the last month or two. The BHC team spent most of January out in the community running Collaborative 101 webinars. And if you missed a Collaborative 101, there's going to be a link to a recorded version at the end of this presentation. I definitely recommend that you watch that if you haven't attended one. I think it's probably the most important presentation for where we are today. The team has done sort of rural collaborative 101s with each of the 5 rural counties, and those sort of happened a little bit faster. The rural ones are smaller, fewer participants, and with the pre-existing county coalitions, we sort of had a lot of infrastructure there. Spokane, because there's so many partners and it's such a larger group, is on a little bit of a slower track as we figure out how to manage all of this. And I'm going to let Charisse give a quick update on where Spokane County is.
Great, thanks Hadley. So again, the communication that's coming out later this week, and I believe it's Thursday, will really outline the expectations of partners as they look to make a little bit more formal of an agreement. Actually, it's a lot more formal of a agreement or engagement, marriage, however, whatever the theme is for today, in regards to the collaborative structure and moving forward. So when partners receive that communication, they'll be looking to hopefully participate in the collaborative. And if you're in Spokane, one of the expectations is that you will participate in the Spokane Collaborative. We've been spending a good deal of time kind of structuring that out, recognizing that we're going to have anywhere from probably 80 to possibly, if everybody participates, over 100 participants in the Spokane Collaborative, which is much different than the rural collaboratives, many of which have been organized and working at some level for many, many years in some counties. And so just wanting to give some recognition that the rural collaboratives in some ways may be a little bit further ahead than the Spokane Collaborative. And so we're really wanting to spend some time in March putting together some framework and structure and getting the Spokane Collaborative off to hopefully a very good start. The ideal, or the idea is that at some point the Spokane Collaborative will be its for the most part, its own functioning governing body. And recognizing that the goal of Medicaid transformation is sustainability, and I think most people would agree that sustainability really comes from a community initiative and intent, and not necessarily from a top-down structure. So, but with that goal in mind, we really need to convene the group. And so we're going to be having 2 meetings in March, one on the 21st, which is a Wednesday, and that will be from 1 to 4 here at Better Health Together. And then a second meeting on the 27th of March, which is a Tuesday, also 1 to 4 here at Better Health Together. And we're going to be convening everyone who has made a collaborative commitment for Spokane County. So we'll gather all the partners, and we'll really be going over and focusing on what are the roles and expectations, not only for the collaborative, but for each individual partner, and how did those two mix and mingle and work together. And then really focusing on going forward, and what does the governance look like, how should the Spokane Collaborative function, kind of a leadership role as that goes forward. And then also, again, focusing on the support that Better Health Together will continue to provide as the Spokane Collaborative goes forward. So again, I just want to highlight March 21st, which is a Wednesday, and then March 27th, which is a Tuesday. And one last time, it is the expectation that if you're going to sign that collaborative commitment, that you attend those two meetings and then subsequent meetings from there going forward. So I'm going to pause for just a second. Hadley, and do we have any questions in regards to the Spokane Collaborative?
I'm going to unmute if anyone wants to ask a question.
Okay, so you have been released for the rest of the day. We called you.
Okay, I'm muting again.
Well, it sounds like I'm done for the day. So.
Could you just repeat those dates one more time?
Absolutely. So March 21st, which is a Wednesday, and that meeting will be from 1 to 4 in the afternoon here at Better Health Together in our large convening room downstairs. And then March 27th, which is a Tuesday, again from 1 to 4 here at Better Health Together.
And we'll include those dates in both the Leadership Council notes and in the communication that goes out on Thursday with more details.
And again, this is Charisse Pope, and a number of you, I think, know me or hopefully know me. And so if you have any questions through this whole process, and it'll be included in the communication that goes out from us later this week, feel free to give me a call or an email. Always happy to help and support.
All right, thanks, Charisse. So the next update that we kind of want to give is talking about our technical councils. So we sort of mentioned this earlier on the call, but this year the Leadership Council itself has sort of expanded as now we have all of these technical councils that are doing sort of more specific and setting specific work, informing how our transformation plans progress. So these technical councils have really been forming, at this point now, all of them have formed and had at least some initial orientation meeting. Not all of them have their whole councils built out. But I just want to give a quick update on the progress of these groups. So our Provider Champions Council is one of the farthest ahead groups. They've been meeting since before the new year. And Charisse has been leading that one, so I'm going to hand it back over to her for a quick update there.
Great, thanks, Hadley. So the Provider Champions Council, and again, I'm new to this, but I believe started convening in November of 2017. And they've been spending a great deal of work and time in regards to the BRE collaborative and the collaborative care models for bidirectional integration. That, I just want to kind of take one step back and say the Provider Champions Council is primarily providers and administrators of primary care and behavioral health care. And so, again, just focusing on that bidirectional integration by the makeup of that group. On the 26th, next Monday is our next meeting, and the Provider Champions Council will be making recommendations either on the BRE or collaborative care model by setting. And then we will also be taking a review of our draft assessment that will be going out to each primary care and behavioral health provider once those providers have signed the commitment to be a partner and be a part of the Spokane Collaborative. I'm pretty excited actually about that assessment because it'll really give all of us a great indication of where we're at as a integrated system of care, number one, and number two, hopefully identify any gaps and needs for technical assistance and supports as we go forward. So that's our work on the 26th. As we go forward, just looking at another month or two, we're going to be doing work around opioids, long-acting reversible contraceptives, and then also fluoride.
Thanks, Charisse.
Thank you. Any questions, Hadley?
Not in the chat. I'm not going to take us off mute because I think somebody has brought us to some sort of fun outreach event. But,
We're fine.
if I see one come in the chat, I'll share.
All right, thank you.
All right, so on our other councils, the Community Voices Council had its first kickoff just 2 weeks ago. That group is co-chaired by Phil Tyler, who is one of our board members and a local community advocate, and as well as Marion Lee, who is a community health worker trainer and runs the Community Health Worker Network of Eastern Washington. So she's been a great resource for community health workers and advocates throughout our region. We had our sort of kickoff just to talk through the goals and expectations of this group. This council will be made up of 51% Medicaid beneficiaries and really serve as a consumer voice throughout transformation work, so that as we are developing plans, we have a body that we can go to and say, okay, how would this actually work for you as someone who is using this service? We also expect that the Community Voices Council is going to do some work on setting some level of equity goals that will be tied to the Community Resiliency Fund and some HCH priorities, so that we can make sure that in the work that we do, we are being intentionally very impactful about decreasing health disparities. The Waiver Finance Work Group has been, and the last thing I want to say about Community Voices, is we have not completely finalized our recruitment plan yet, so we haven't done extensive outreach to Medicaid beneficiaries, aside from the folks who have submitted a nomination to us from the last Leadership Council, where we sent out a nomination form. We have a meeting just in a couple weeks to talk through building out a recruitment plan with our co-chairs, so that we can really be thoughtful in figuring out how we're going to balance the intense diversity in our region when it comes to rural and urban, racial and ethnic diversity, diversity of life experience, and how we can really build out a balanced group that's going to provide strategic input on the specific populations that we want to work with through transformation. The Waiver Finance Work Group has, you've sort of seen the results of their work in the funds flow presentation that Alison just gave. They've really been responsible for setting the recommendations for how we're going to allocate funds, and we'll continue to do that throughout the waiver period. And finally, we have here it's listed as the CCC Advisory Council, which is the Community-Based Care Coordination Advisory Council, and we're going to just refer to it lovingly as the Hub Council, because that's a lot easier, so you'll see an update to this slide soon. And the Hub Council is really going to be setting recommendations for the care coordination elements of our project. And this is also sort of a precursor to, if we certify as a official Pathways Hub, there's a requirement to have a community advisory board, so this sort of serves as a pre-body for that, for when we have to have our community advisory board for the Hub. In additionally, the Tribal Partner Leadership Council meets once a month with tribal leaders throughout the region to look at upcoming decisions for the waiver projects and how they will impact tribes. And the Regional Integration Team meets as needed to discuss issues related to integration throughout the region. So these bodies pretty much are meeting monthly, sometimes more, and their work is informing the overall policy and recommendations for how we're going to approach these projects. Once we get to the place where collaboratives have started developing their own plans, these different councils will also start to vet and sort of give advice on how those plans are developing. And there's a question on where we can find out who is on the different councils. That is a great question. We are actively, I'm excited to say, updating our website to include a better landing page that shows all of the different technical councils in the collaborative, as well as who's on those different groups, when they're meeting, and just all the information that you would need to know about those groups in one spot. I expect that we will have that done just in the next couple weeks. So for now, we will be getting at least all of the charters are up there, and I can send out a link. I'll include in the notes a link to the site on our webpage that has the charters for those different technical councils. But hopefully in just the next couple weeks, it'll be a lot easier to navigate and find all that information once we get the new page on our website. Okay, so with that, I'm just going to run through some of the quick next steps that are coming up for folks in the ACH and folks in the collaborative. Like everyone has mentioned, we are going to be releasing updated information on Thursday with the next steps. So be watching your inbox on Thursday for sort of a packet of information that includes the expectations for the next couple months throughout as we're planning for our transformation project. So on the 22nd, we're going to be releasing what we're calling our collaborative MOU for all settings. And this is really the first sort of commitment to participate in the ACH work. We are asking this to be returned by March 12th. If you want to receive payment for this milestone by April, we are, the way it works with the payments that the ACH receives, we have to upload all of the providers who are going to be partnering with us into a financial executor portal that's run by a third party. And once we enter your information, you will get an email that asks you to register for the portal. So there's a few days between when we put your name in and before you can get paid, because there's steps that you have to take in order to sign up for that portal. So we sort of have to make sure that we get folks into the portal before the 15th of each month. Otherwise, your payment gets delayed by a month. So while we'll still be accepting commitment forms past the 12th, we are really going to be working towards the sort of expedited timeline. And I think for moving forward for the next couple months, I think you're going to see on all of our deadlines, it's sort of going to look like this. Here's the date if you want to get paid early, if you want to get paid in the next month. And here's another date if you need more time, but recognize you will not get paid for a month or two more. And again, we'll make that clear when we send out the commitment form. So the form is, it's not written in blood. It's not a binding letter for the whole entire demonstration period. This is specific to planning activities in this year, really moving up to October. So October 1st, BHT has to submit a region-wide transformation plan that includes what partners are going to do what pieces in order to meet the metrics. And we are going to spend this year working towards getting that plan submitted. So the expectations for serving in the collaborative right now really include participating in the meetings, completing a current state assessment that BHT will be sending out, sharing relevant data and information with BHT and the collaborative partners so that we have the information we need to make a comprehensive plan, and then really developing individual transformation plans within your own setting or showing up as a partner in those transformation plans. And then finally, as individual partners start to build their plans, it'll be the expectation that the collaborative is sort of aggregating those up into a county-wide summary of what all the different folks in that collaborative are going to be doing. So alongside of that, we have some next steps to access the FIMC dollars. So when we send out this note on Thursday, behavioral health providers will receive an additional communication about FIMC dollars. So that will be another commitment, basically saying that you are agreeing to move forward you're agreeing to participate in transitioning to fully integrated managed care by January 1, 2019, and to be working towards being integrated or being prepared to contract with MCOs by that date. The communication or the agreement will also say that you are going to complete an assessment. You understand that the payments that BHT is offering are paid for milestones. So the first milestone will be turning in the commitment. The next would be taking an assessment and sharing the answers with BHT. And then turning those answers into a plan and sharing the plan with BHT. This assessment is really going to help us with sort of a current state for what do behavioral health providers in our region need right now to be ready to integrate, and this will help us develop the most useful technical assistance package we can, sort of figure out what we can be spending some dollars on to have the biggest bang for our buck and help providers with this transition. And then I mentioned these participating provider transformation plans. So those are going to be heavily informed by the assessment. So once everybody returns their commitment forms, we will make sure that you get signed up successfully for the financial executor portal. And once we have confirmation that you are signed up so that we know you can actually receive money, we will send you an assessment. There are two assessments. Not everyone is going to be asked to take one. There's what we're calling the Medicaid Transformation Capacity Assessment. which runs through questions about your setting and interactions with bidirectional integration, with opioids, and a couple of different elements of the projects that we're working on. And this assessment is really going to help us build sort of a gap analysis on the infrastructure that we have to support these projects. And then behavioral health providers, as I mentioned, will get an additional assessment that's for FIMC billing. And that one will come with an additional payout. So if you're an FIMC provider, or excuse me, if you are a behavioral health provider, then you have the opportunity to get paid for 2 different assessments. The technical councils, once they receive the results of the assessment, will use those to help develop sort of setting requirements that will build out a framework for what's going to be in the project. So what are we going to require the collaborative partners do in a project, and sort of what are the menu of options that they can look at as they're exploring their own transformation plans. At this point, we're expecting that behavioral health, primary care, and pharmacy are going to be completing actual work plans and sort of implementation plans for their own settings, because those are the settings that have they have key elements that are required in order to have projects be successful, and they're taking on considerable more risk for getting these projects off the ground and meeting the metrics. So we expect that in June, these providers will be asked to submit to us a transformation plan for how their own setting, how their own shops, their own 4 walls basically are going to engage with transformation. So that's sort of a snapshot of what's coming from now until June. And then between June and October, we'll really be taking those individual plans that we've got from the collaboratives and translating them into a regional plan. There'll be a lot of back and forth with the collaboratives and the technical councils as we make sure that we have a plan that's going to be viable for our region. But we just wanted to give you sort of the quick snapshot. There's going to be a lot more details coming when we send out this information on Thursday. But for right now, I'll pause again and see if there are any questions on sort of this process and what's coming for collaboratives. And I'm gonna take a chance and unmute us here. We are unmuted if anyone has any questions. Okay, hearing none. That's a great question, Jenny. Is the program operating on a fiscal year end, June 30th? Allison, are we on a fiscal year or a calendar year?
Well, BHT is on a calendar year. The waiver is on a calendar year, and the state's budget is on a July 1 fiscal year.
Okay. I hope that helps, Jenny. And then Jack Davies is asking if there will be an MOU for the collaborative and for each provider organization in the collaborative. No, these MOUs are going to be specific to organizations in the collaborative that says that you are going to participate in your county collaborative. So it commits you to participation at that collaborative table, which may be the Spokane County Collaborative or, the Lincoln County Collaborative. It may be multiple collaboratives. And in that, it's also committing you to partnership with BHT and to continue working with BHT. Who distributes the MOUs? We will be sending out a large communication to basically everyone who's been participating in collaborative work. Anyone who's attended a Collaborative 101, the folks that we have on lists through, through the rural coalitions as well, Jenny. So you guys will get that MOU, and you can help make sure that people that you want through your collaborative are seeing that. But mostly it's just going to come from us. We'll send a big communication out to our whole entire listserv on Thursday. And there'll be detailed instructions for how to submit in the packet that we send out, but we have created a page on our website where you'll actually log in and upload it so that this will be a little more streamlined. We don't have to worry about losing emails and just the massive, massive influx of commitment forms that would have to flood somebody's email box. And yes, this presentation will be available through email. If you're on the webinar right now, you can click the materials box and you should be able to download it directly. And if that's not an option, we will send out slides when we send the recap just immediately after this. All right, I know it can take a couple seconds to type a question in, so I'm gonna wait a little bit longer. We've added another practice of sort of including a resources slide at the end of each presentation if there's other stuff that I think would be useful to follow up on. This slide includes a link to our Collaborative 101 webinar. So if you missed a Collaborative 101, I really can't emphasize enough how important I think it is to watch one of those. That really runs through what is the collaborative and what its role will be throughout transformation. We also have a link to all of the Leadership Council dates in 2018 and all of the board meeting dates as well. So you can get those on your calendar if you are eager to engage with BHC. Okay, and with that, I hear no more questions. So feel free, if you do have follow-up questions, feel free to respond when we send out the note, and BHT staff can get back to you. But otherwise, I'm going to hand it to Pam to sign us out.
Thanks for joining us. I think Hadley's actually getting us here early today, which is awesome. I just got about 30 minutes of my day back. I would urge you to look at the materials, download them, go through them carefully, and if you have questions, don't hesitate to email Hadley or BHT staff as we move forward. Thank you again for joining us, and we will see you soon.
All right, thanks all, and please, if you have time, take the exit survey so we know how we did today. Have a good rest of your day.